So I'm going to hand over first to David May and David Taylor. So David May is a statistician working at the Office of National Statistics. He currently leads the mortality statistics team at ONS, which delivers all those regular bulletins that we see about suicide and where, you'll often hear it hit the news. And then David Taylor is the senior research officer on the team. So I'll hand over to the Davids. And if you put your questions in the chat, we'll get to them after all the speakers have spoken.
Thank you. I'm just going to open up and then David will speak a little bit later on as well then. Yeah, where there's two Davids, we could get a little confusing, but yeah, I'll be presenting first. I might not be able to see hands and things when I'm presenting, but if you can't see the slides or anything goes wrong, just give me a shout and I will.
They're there, David, we can see them.
Great, thanks very much. So yeah, thank you for the introduction, and that was really useful and saves me a bit of time on this slide. But basically, we'll be covering the latest data on kind of suicides that we publish at the ONS for England and Wales, but obviously with more of a look into Wales then, and also David Mays will speak a little later on around some of the developments we're making in our suicide statistics going forward. I'm going to stop sharing and share another slide pack because I think this is an old slide pack. So apologies for that. I'll have to do it the old-fashioned way. And okay, sorry. Can you let me know if you can see those?
Yes.
Okay.
Yeah, we can see them. They're still in presentation mode. There we go.
Cool. Thanks very much. So yeah, I've covered. So the first slide here is really just to give a bit of background information to how we kind of source our data in ONS and where the suicide statistics that you see come from. So you may be aware that it's kind of a legal requirement since 1836, as you can see there, for all deaths to be registered in England and Wales. And this is where then ONS get provided the data from the local registration services in partnership with the General Register Office then, and we kind of get all the data around deaths that are registered in England and Wales. Once we have this data, then we have a team within ONS who kind of code that data in terms of causes of deaths, and this is done according to kind of World Health Organization, the ICD-10 codes, which you may be aware of. But then this obviously helps with coherence and kind of international comparisons, then using kind of agreed rules across this. And obviously suicides then is one of the causes of death that we get within our data, and that's how we produce the statistics on that. To provide the most complete information, we do publish on death registrations rather than when deaths occur. And David will go into this a little bit later on as to the reasons for that, but it's mainly due to have more complete information and to account for kind of delays in registering deaths. Okay, just to move on to regular publications that some of you may have already seen, but we kind of have two regular publications that kind of go out regularly. So obviously one of these is our annual suicide release, which covers England and Wales, and we do have then separate breakdowns for England and Wales in there. And this just breaks things down by sex, age, as you can see there, and kind of area of usual residence then across England and Wales. And alongside this, we also have quarterly suicide statistics, which go out across the year. These releases are kind of far shorter than the annual release, but are just there as a headline release to kind of look at the trend over time and just ensure we're kind of we've got the most timely data, I guess, on suicides that are occurring or that are registered in England and Wales. As well as having our regular publications, we also from time to time publish kind of analytical pieces which are more ad hoc and kind of can often, I guess, be commissioned by by other researchers or by other organizations, or it may be that we kind of have time ourselves to look into the data as well. You can just see a selection of them here. The publication at the top left there that I've included around suicides in higher education students is kind of our most recent one that we've done in this space. And all of these releases are done by mainly by data linkage, where we kind of take our death registration data, which we use from our kind of annual suicide statistics, and we link them to other data sources. So, for example, with the higher education students, we linked our data to the higher education statistics agency student records, which then allowed us to kind of identify suicide deaths that we had in our data that were happening to higher education students, and then we could look at the risk of that and kind of see if it was kind of higher or lower than the general population then. And then yeah, you can see we've done a kind of few other publications recently. So so yeah, one kind of really important one was around looking at armed force veterans, and we've also done others looking at different at-risk groups then, obviously those in prison custody and things like that we've done. So yeah, these can be really interesting pieces that we put out as well alongside our regular releases. And just to talk about a kind of most recent annual release, this was looking at 2024 suicide death registrations. And this was published on the 3rd of October this year. So as we've already mentioned, this covers England and Wales. But alongside this year, we published 2 other articles, which were kind of really important for us. So the first one, you can see that the second one on the slide there, you can see is around the standard of proof in England and Wales. And this is where you may be aware that in 2018, there was a kind of change in the standard for of proof for kind of a suicide, going from beyond all reasonable doubt to on the balance of probabilities. So this certainly has an impact in our data, and we'll talk a bit more about that later on as well. And as well as this year, we also had a user consultation that went out prior to our annual release, which some of you may have actually filled out. So we also published an article just I guess summarizing what the findings were from that consultation. So again, this will be covered on later in the slides, which David Mays will talk through later on. So yeah, just to give you an idea of what we're planning in future. Okay, so just to go on to, this will be mainly taking data from our annual release, but I'll also look at a few other bits of data, but this is just to look at the latest trends that we're kind of seeing for Wales. So the chart you can see here on the slide is taken from our most recent release. So it obviously just plots the kind of suicide rate for registrations for Wales and England separately. So obviously you can see there that there does seem to be, or there was an increase this year in suicide deaths that were registered per 100,000 people in Wales. So it increased, it was 15.7 suicide deaths per 100,000 in 2024 in Wales, and this had increased from 14 that we saw in 2023. And as you can see, yeah, the rate there for England in 2024 is kind of quite a bit lower than Wales now, but as will become apparent across the kind of data when I speak through it, is that in Wales, in comparison to England, in terms of the actual number of deaths, they are kind of relatively low. So as you can see with that chart over time, that there's quite a lot of volatility in our data. So yeah, it can be quite difficult to pick up what the trend is, but in the most recent period, as I've said, there does seem to be an increase. So obviously it'll be interesting to see, and really important for us to kind of track that over time now and see if that's kind of something that'll continue increasing, or whether, similar to other years that we've seen historically, whether there'll just be another dip and it's just another pattern of kind of volatility there. So yeah, that's kind of, but yeah, I guess to look at, if we were to go back to the beginning of that series, where the rate was around, in 1981 was around 12 deaths per 100,000. So again, you could say there's been quite a big increase in the most recent time point compared if you to look or go all the way back to the beginning of our time series. But as we've mentioned, there's obviously a lot of change during that time, and a lot of volatility in the data over year on year then for Wales. And this is just a very similar chart, but to kind of show the breakdowns by sex. And as yeah, I think a lot of people will be aware that we do see obviously that suicide rates are higher for males, which you can clearly see with the green line here. And they have been consistently from the beginning of our time series compared to suicide deaths in females. So yeah, obviously the pattern for or the increases that we see overall for Wales, you can see that it does look like it's being driven by kind of increases that we've seen for males there in 2024, where there's the rate for males was 25 suicide deaths registered per 100,000 people in 2024 compared to 22 suicide deaths registered per 100,000 that we saw in 2023. We did see a small increase for females as well during that time point, but yeah, obviously a lot smaller than what we've seen for males, where it increased from 6.3 suicide deaths registered per 100,000 in 2023 to 6.8 suicide deaths in 2024. And again, if we go back to the beginning of the time series, it does seem as though the rate at that we're seeing in this current time series is higher for males compared to what we saw maybe back in 1981 at the beginning of our time series, whereas for females it does seem to have decreased. But obviously in kind of recent years, it's just kind of been, I guess, difficult to pick up what the trend is there, and it's kind of been a bit volatile again, but generally quite flat, I suppose, compared to what we're obviously seeing in 2024 now. So as well as just looking at things at a national level in our release, well, in terms of the commentary, we do focus on a national level, but we also do publish data in our data sets which look at local authorities. So we just wanted to include this here just to make people aware that data is available. Just because of obviously the relatively low number of suicide deaths that we see in Wales, to break it down to local authority level, we have to combine our data over a 3-year period. So you can see this is the most recent period we have, which is looking from 2022 to 2024. And yeah, we just wanted to put this table in just to kind of, obviously highlight the data available, but then also to look at, you can see there's quite a big variation across local areas in Wales, where obviously with Ceredigion on there, that there's quite a low suicide rate in terms of 8.4. And obviously that's quite a bit lower than the national average as well. Whereas for somewhere like Blaenau Gwent, the rate is obviously a lot higher, and also higher than the national average at 20.1 suicide deaths per 100,000 registered. We haven't looked so much over time to see if this is just kind of a snapshot of the most recent period. So, but that data is available online if people did want to kind of have a bit of a dig into that and just generally see if these areas tend to be areas that are generally higher, or whether. But I think due to the small numbers, I think there is likely to be a lot of volatility over time, and you might see that certain areas were historically quite high in terms of the number of suicides, but could be quite low now. But yeah, obviously there's going to be that volatility over time again, I think. Sorry. Okay. So as we mentioned earlier, we do publish the majority of our statistics on suicides on a registration basis, but here we've just picked out the data if we were to look at occurrences rather than registrations, just because we know there are kind of long delays in deaths being registered in Wales, particularly for suicides. So it's not necessarily that the pattern for registrations that we see for suicides are going to be the same as if you just look at when a suicide actually occurred. So this is looking at the most recent time point we have for occurrences are for 2023, again, given the fact that we have these long delays in when a death is registered. So it can be difficult to kind of look at really, or to provide timely data on that, because yeah, it's just the completeness of the data won't be very good in terms of recent years. And I guess you can kind of see that with particularly for males there. From 2018 on, we do see that the rate is quite high for males again, even if you look at suicide occurrences compared to registrations. And I should say, sorry, on this chart that the the bold lines there are for Wales, and we've just included the kind of faded line for England there, just to kind of give a comparison. So you can see for females, they do track each other quite closely, I guess, and the rate for suicide from females in Wales is quite similar to what the level that we see in England as well. Whereas for males at the top there, you can see that, especially in recent times, the difference has become quite a bit larger, or has kind of moved away, from England in terms of the rate for Wales. So as we saw in the registrations, there could be something here where we are generally seeing that the kind of suicide rate for males in Wales is increasing quite a bit. But as I mentioned with occurrences, it's quite difficult to look at those most recent time points there. For example, in 2023, you might say that there's been a decrease if you to look at that top blue line compared to 22. But we're kind of aware that as more suicides are registered, or more deaths are registered in Wales, it's likely that the number of occurrences will increase, or the number of occurrences that happened in 2023 will increase as kind of more suicides are registered. And David Mays will talk a bit more about this later on, a kind of around how long those delays are and how it affects our data. And just to give a little bit more detail on this data as well, we've broken it down by age groups here, just to kind of give an idea of or to give an idea of the age groups which are kind of more at risk in kind of Wales. And yeah, you can see again, so this is just providing the data for males, sorry, and on the left-hand side in the bold, again, you've got the rates for males in Wales over time. And on the right-hand side, we've got the rate for England, sorry, in terms of suicide rates for males. Again, as we've seen throughout the slides, the data for Wales is kind of far more volatile than what we see for England, just because of the kind of low number of deaths in Wales. But again, we can see that historically that 25 to 44-year-old group has been kind of the highest for Wales in terms of the number of suicides, or the rate here. So, but we've seen in recent times that the kind of more middle-aged, or the 45 to 64, there has kind of increased, and in the most recent period has actually overtaken, I think, the 25 to 44. But again, because this is occurrences, we might see that changes, and or it might be that the 45 to 64 increases even more. So it does become, it does go above that 25 to 44-year-old group then. And this is kind of different to what we see for England, where, well, I guess you do see for England as well that 25 to 44 and the 45 to 64 are the highest as well, with the 10 to 24 being a kind of a lower risk. And that's consistent for Wales and England there. We also put this, or we've broken this down for females as well in Wales, and also plotted that alongside the rates for England. Again, it's quite difficult to look at the trend for females because of that volatility in the data, and you can see there's some years where we kind of see sort of anomalies, I guess, where you kind of see this sharp increase in rates, but obviously it kind of drops back down then. So yeah, it's quite difficult to pick that out. But I guess one thing we could say is in the most recent time periods, we are seeing consistently as what we see with males, is that the 45 to 64-year-olds do have the highest suicide registration rates for females as well. Alongside, obviously, and the 25 to 44 is also a lot higher than the 10 to 24, and very close to the 45 to 64-year-old suicide rate. And something we did pick out is that the kind of numbers or the rates that we see for Wales for females are kind of a lot closer to what we see for the females in England as well. Whereas I think for males, especially for that 45 to 64-year-old group and 25 to 44, we did see that the rate in Wales is quite a bit higher than what we see in England. So that was just something we picked out here, that it does seem that for females, it kind of aligns a lot closer with the trends that we see for England. Right, I'm just going to pass over to David now, who will speak through the developments that we're making to our statistics and how we're hoping to improve our suicide statistics going forward.
Brilliant. Thanks, David. Yeah, I'm going to cover all of the thinking we've been doing around improving our suicide statistics, which is part of a wider piece of work we're taking forward to improve all of our mortality statistics. So if you can move to the next slide. The background really to this work is around how we present our statistics on mortality and suicides. As David mentioned, all of the ONS statistics currently are produced based on when the death or suicide is registered. So yeah, we're presenting the number of suicides registered in a given year. And the reason we do this is because of the system we have in place in England and Wales, where ONS will only know about a death once it is registered. And as we've heard from David, the gap between when the death occurs and when it's registered for causes of death like suicide can be a long time. And that is the reason really we publish on a registration basis, is because the data is more complete and it enables us to produce a more confident number really if we use registrations. But it can cause us some communication challenges. So, you know, a good example for the latest suicide registrations in Wales. So we had 436 suicides registered in Wales in 2024, but actually only 22% of these actually occurred in 2024. The vast majority, so 78% of them, occurred in 2023 or before. And then if we move to the next slide, this chart is actually quite useful. So this chart shows suicide registrations in Wales by the year of occurrence. And what you can see that in the blue line, so you can see the 22% of 2024 suicide registrations that also occurred in 2024 there. And you can see that this figure has gone down massively. So in the early 2000s, we were seeing just over 60% of suicide registrations in a given year also occurring in that year. And this has happened because of, you know, increasing registration delays. And if we move to the next slide, we're doing some thinking really about how we solve this issue, because we can't really be confident now, given the increase in registration delays, that the trends we're seeing in registrations and occurrences are aligning in our data. So we're doing a lot of thinking about how we could solve this issue. The first one's straightforward one is just trying to be better at how we communicate our suicide statistics, and in explaining that we're talking about registrations, not occurrences. We've done a lot in the latest annual suicides release to try and improve how we communicate that. We are also considering whether we could switch our suicide statistics to publish on an occurrence basis instead. And then exploring new data can give us more time data, like the real-time data, and you're going to hear a bit more about later. I'll say a bit more about each of these in the next few slides. So I think the first one, if you move to the next slide, David. Hasn't moved on for me.
Sorry.
Sorry.
Yes. Is that working for you now?
No, it hasn't moved on.
No.
Okay. Cool. How about now?
No, still not.
Okay. I will stop sharing for a minute and try and re-share. Okay.
I guess while we're doing that, David at the moment, one of the questions was about, I sort of quickly answered it, but just about the impact on COVID on occurrences versus registrations.
Yeah, I mean, we haven't really looked, so we're still kind of thinking through how we switch to occurrences. We've looked on a registration basis. Obviously, you see a lot less suicides registered in 2020 because of COVID, but we haven't really looked at occurrences and really seen much of an impact really with COVID, for reasons that I'll cover in the next few slides really. about the comparability of the occurrence data over time.
I think
But
the other David may have frozen.
let me, I'll share my versions of the slide and we can get moving. Bear with me 1 second. Sorry, it's just loading.
I can see them.
Let me just move it forward and
And that 22%, I was quite shocked by that when I first saw it.
yeah, and I think that's the reason we've decided to act now, because yeah, we can't be, as I said, we can't be confident that the trends in registrations and occurrences are necessarily aligning. So that has prompted us to take action. But I think the slides
Yes, I
be
can see
seen now,
them.
so I can carry on. So yeah, I was saying a bit about basically we're trying to improve how we communicate the occurrences and registrations within our annual suicides release, and we made a lot of effort in the most recent release to better communicate our occurrence data. The issue we have with it, really, as David said earlier, is with occurrences for the most recent years, the number of occurrences will be lower because we haven't had the registrations in for those years, which makes it very difficult for us to compare occurrences over time. But what we have done is adjusted the number of registrations that we're using for each occurrence year to make them comparable. So we've done this for the Welsh data. So this shows age standardized mortality rates over time for Wales. The blue line is based on all of the registrations we have at the moment. And at the moment, the occurrence rates for 22 and 23 will be lower because we haven't had as many registrations. But when you adjust for that and you use the same registration period for each occurrence year, so we've only using 15 months of registrations after each year, we can see that the occurrence data actually points towards there being an increase in the suicide rate in Wales in 2023. So that's quite useful to obviously present that information in that way. And by making that adjustment to make the occurrence data comparable, it definitely has, helped users interpret the data. And as I said, we're trying to switch all of our mortality statistics to be occurrence based. This is difficult because if we did switch to occurrences, what we might have to do is wait a really long time for those registrations to come in to give us that accurate occurrence number. But it wouldn't be very useful for users to wait that long. So what we're trying to do is do some statistical modeling to try and estimate the number of suicides occurring at given points in time to basically correct for registrations that we don't have yet. So we're working on that, and we're going to provide more information to users next year, and it will inform the next annual suicides release that comes out in the autumn next year. And related to all of this, we did run a user consultation earlier this year. So it was run in April. We were asking for feedback really on how we present the registrations and occurrences for suicides. We got a really good response, so 92 responses from stakeholders. We presented basically 3 options, and we got users to vote on each of these options. The first option was really don't change much in what we present and focus on the registration still, with limited commentary on the occurrence data. But the second option was more of a hybrid option, so presenting both registrations and occurrences within the annual suicides release. And then the third option was a bit more radical. This was to switch all of our releases to be occurrence based and move away completely from using registration data. And sorry, this just say a bit more about the types of people and stakeholders that responded. We got a lot of responses from local government, central government, arm's length bodies, but also a lot of responses from academia and the charity and voluntary sector as well. So a really good response rate to the consultation. And what we found is that the majority of respondents went for option 2. So this is to present both registration and occurrence data within our annual suicides release. And I'll quickly say a bit about why people who chose this option wanted this option. So some of the main reasons were continuity and comparability. So because we presented registration data for suicides for so long, I think a lot of users felt that just moving completely away from that would be a mistake. So having that continuity really of presenting the registration still was why a lot of people preferred option 2. There was also the timeliness point as well. So the registration data we have is more timely and complete. So users obviously wanted us to retain that within the release. But users who chose this option did recognize the benefits of presenting occurrence data as well. So they felt occurrence data gives us different insights, and it can also help us, spot like clusters in terms of suicides at a local level, for example. And generally, people choosing this option thought that having both registrations and occurrence data gives more context and a better overview of what's happening in suicides. And they recognise that this approach would, help inform, prevention strategies as well. And they also mentioned signposting to the real-time suicide data as well, more prominently in our releases, which is something we want to do more going forward, because that obviously gives us a more timely source of data than we have in the ONS data. And they did as well, users who chose this option, they wanted a similar focus for registrations and occurrences. So they felt that having an equal weighting within the bulletin would be preferred. So that is something we're going to try and move towards going forward. And overall, really, they thought an approach of using registration and occurrence data will help improve misinterpretation of our suicide statistics and also improve public understanding of suicide statistics going forward. So that is the option we're going to be running with going forward for our annual suicides release. And then just to sum up, really, our next steps, we will be incorporating this into the next annual suicides release. So there will be more commentary in the next release on the occurrence data. We made a small step towards that in the most recent annual suicides release, but we are working on a nowcasting method to try and produce more accurate occurrence-based suicide statistics, which we want to incorporate in the next annual suicides release next year. And that's everything we wanted to say from the ONS. Here's our contact details if you do want to get in touch with us. But I think, put any questions for us in the chat. I think we're going to do them at the end. But I will stop there. Thanks very much.
Thanks so much, both. If you're okay to stop sharing, I guess, whenever we're talking about data, I guess it's always important for us to say that none of us forget that we're also talking about individuals and losses to family. And I guess it's understanding that when we're talking about these things like, changes in the burden of proof, registrations versus occurrences, the delay in registrations, as well as giving us lots to think about in terms of the data, also is families waiting. And, and I think it's often really useful to say that everyone working in this field appreciates it. And some of the times when you hear us really getting into what does the data mean, the numbers are small, is it random, that comes from everyone trying to understand how these rates and numbers and figures can translate into meaningful change. You know, who should we be focusing our efforts on? So I think I can see that there's been a number of questions generated, but if we move on to our real-time suicide surveillance, and I guess if I was thinking about ONS statistics and RTSSS statistics that you'll hear about now, they both have their strengths and weaknesses, and it's looking at both together that gives us really the sort of intel that we need to do that sort of work where we're thinking about policy and practice. So Rhys Gibbon, I have worked with for many, many years on suicide data over the years when we used to do the midpoint reviews for the previous strategy. And Rhys was pivotal in producing all those graphs that really focused around Wales. He's a principal public health intelligence analyst and leads the team responsible for analysing the real-time suspected suicide surveillance data. I've also worked with Ros for many years, particularly on the child death review. And some of you may remember that we worked with the child death review programme to produce 2 reports on child deaths by suicide that had a lot of impact in changing things around child deaths. But Ros now, partly because of the amazing work she did in the child death review, who's leads on the RTSSS system. She's a consultant in public health and medicine at Public Health Wales. So I'm not sure which one of you is going to speak first. I'll hand over to you.
Thanks, Anne. I'm going first, and then I'll hand over to Rhys. Can everybody see the slides, first of all?
Yes, but they're not on presentation mode yet.
Hopefully they are. Are they now?
Yes.
Yes, brilliant. Okay, thanks very much. Thanks for the introduction, Anne, and thanks everybody for coming along. So this is what we're going to talk about in our presentation. So I'm going to talk about a bit of background to RTSSS. I know many people would have heard this before, but there's a lot more people here than we usually present to. So just a bit of a background. Then we're going to talk through the 2024-25 annual surveillance report findings. So we published this report at the end of November. So Rhys will talk you through the annual findings, and then I'll talk through some insights from the first 3 years worth of data. And then we'll just end with what's next for RTSSS. And just as Anne has just said, and also Matthew, thank you for putting that in the chat earlier on, just a warning that this is sensitive data, and then just, if anybody needs any immediate support or support in the future, these are some really good sources to reach out to. And particularly what Anne was just saying, that we do acknowledge that the data we talk about, data are people. So when we're talking about population level data, so it's important to remember that each number is an individual whose death may have been preventable and whose death will be having a significant and enduring impact on many others. So we talk about data, we talk about counts, rates, trends, but we do acknowledge this very much. And as Anne has just said, we are coming from a place of trying to understand the data and how we can improve things and prevent things in future. Okay, just so a little bit of background on the real-time suspected suicide surveillance programme, which I'll refer to as RTSSS. So we collect information about deaths by suspected suicide soon after they occur. So this started in April 2022. So we're in our 4th year of data collection now, and we've just finished the 3rd year of annual surveillance. So the notifications are mainly received from the 4 Welsh police forces and British Transport Police on a monthly basis. So they send us the information As soon as the death occurs, they will collect information about that death, and they will collate that information over the previous month and then send that on to us. So it's only information that's available at that time. And then we do get some additional information from the NHS Joint Commissioning Committee. So for example, this is when there are patients commissioned in beds perhaps outside of Wales, and if they die by suspected suicide, we'll be informed of those. So that's just, we're trying to capture all suspected suicides of all Welsh residents wherever they may occur. And we also do collect information on non-Welsh residents if they occur in Wales as well, but we look at those separately. We also get additional information from NHS Performance and Improvement. This is in the form of nationally reported incidents. So this is when there may be a death of an inpatient or a death of somebody who's been recently discharged from mental health services, for example. We also glean additional information from the Child Death Review Programme, which is the other programme I lead. So we do have additional information about deaths of those under 18 years old. And then we can also access some information from the Welsh Clinical Portals. This is mental health, use of mental health services and mental health diagnoses, for example, where that is available. It does vary across Wales though. So the RTSSS reports on death that occurred during the stated time period, and they provide a timely indication of deaths by suspected suicide. So as we've heard about ONS statistics just now, so this compares with the ONS statistics, which are published by year of registration. So the actual occurrence of those deaths may have been months or years prior, although we obviously have just heard from David that they have started introducing occurrence data in, and going forward that will happen as well. But you know, there's the sort of the timeliness issue with that data. So although we are able to provide more timely data than ONS suicide statistics, and we can look at emerging trends at this, the data is not as of high quality. And just to reiterate again, they are suspected suicides, not suicides as deemed by a coroner after an inquest. So there is that difference there. So our numbers and rates are likely to be slightly higher because some of those deaths will after going through inquest, they will not be a suicide. They may be there may be another cause. So there's been 3 years since the RTSSS began, and it's important to use caution when interpreting our results due to the relatively small numbers. So we have a relatively small number annually, and even when looking at 3 years worth of data, it's still relatively small. And we don't have the trends data that the ONS have because we have only got 3 years worth of data. So it's just to be cautious of that when looking at our results. And just a note on ethnicity, gender identity and sexual orientation. So you won't see these appear in our charts, in our findings that Rhys will present, because even though we do collect this information from the police, there are data quality issues for these fields. So for example, for ethnicity, it's not from a source where it was self-reported. So it would be possible to link data for research work, for example, using census data, which is what ONS have done. They produced a report, I think back in 2023. They reported on rates in different ethnic groups, but it's not suitable for real-time surveillance because we wouldn't have that information straight away. But there's a possibility of linking data in the future if we can gain access to GP data, which we don't have currently. Then on gender identity and sexual orientation, again, really important. We do collect information from the police, but the data quality is uncertain. But when this information becomes available from a reliable source in the future, we will then explore the feasibility of collecting that and then reporting on it. And it's just to let you know what we do with the data. So we collect all this data, we collect it monthly. We do produce a monthly report, which is taken to a monthly operational group, which is attended by Public Health Wales colleagues, the Police Liaison Unit in Welsh Government colleagues, and colleagues from the Suicide and Self-Harm Programme in NHS Performance and Improvement. And the monthly data is also accessible to local public health teams. We also map this data in terms of location of occurrence and location of residence. So this is to look for any potential clustering and just to have a visual of sort of what's been happening in the prior month. And this is shared on a monthly basis with members of the SSHP team. We also produce an annual report, which is what we're going to be talking about today. So they're available publicly on the PHW website. Our first report was published January 24, the second one December 24, and the third one now in November 25. And we revise the data annually. So there's an extract is taken at a particular time, but there's a very small number that may be added after that date, and then also there may be some additional information that came in after that date as well. So if you wanted to look at previous year's data, it's always best to go to the data tables, which are referred to in the latest report, rather than sort of looking at old reports, because the numbers will differ very slightly. We also produce some ad hoc data queries. We respond to queries and share anonymised data in that way, and generally some of those come from things that are coming up in our monthly operation group reports or from other sources. So I'm done with this section. I'm going to hand over to Rhys now, who's going to talk through the findings from the 2024 annual surveillance report in terms of the annual data. So, and I'll move your slides, Rhys, so if you just let me know when you want to move on.
Thanks, Ros. Excuse me. So yeah, just to kind of recap a little bit of what Ros said. So I'm going to present data from the annual report. So the dates that we're actually covering from, as you can see from this chart, are from April 2024 to March 2025. So suspected suicides that were submitted to us within that period. And you'll also see on my slides that in the box that there is a sort of comparison with the RTSS kind of suspected suicides that we had from previous years. As Ros mentioned, they would be revised from last year. So they, if you looked maybe at last year's annual report, they may not be the same. That's because we have a live database, and so things change quite a bit, and we have some suspected suicides that may come in late. So we revise our data backwards once we those data tables once we have our annual report published. Onto this chart. So this shows a monthly breakdown of deaths by suspected suicide that was submitted to us for Welsh residents. There were 440 deaths for Welsh residents in this year, at a rate of 16.8 per 100,000, and that compares to 352 the year previously at 13.4 per 100,000. 20 deaths came in for non-Welsh residents, and the range month by month sort of range was between 30, which was in June 2024, and 43, which was in December 24. Next slide, please, Ros. Okay, thank you. So this chart shows the deaths by suspected suicide by age group and sex. So it's broken down for males and females. We're going to cover males first. So as I think previously sort of mentioned around the difference between sex and suicides, males accounted for 77% of deaths, and the highest age specific rates in males was in those age groups 35 to 44, and then males 45 to 54, which is quite similar to last year's findings, albeit that yeah, some of the rates might be slightly higher. So and then for females on the next slide, thanks, Ros. So this is the same chart as what I've just shown you. So females accounted for 23% of deaths submitted to the RTSS suspected suicides, and the highest age-specific rates were in females aged 25 to 34, 11.7 per 100,000, and then 35 to 44, and then under 25, which was 8.8 and 8.6 respectively, which is slightly different to last year, where under 25s are sort of in that sort of higher group as well compared to last year. Next slide, please, Ros. We also looked at employment status, and we found that the rate of deaths in people who were reported to be unemployed was at least 12 times higher than any other employment status group, although 24% did have a missing employment rate. So the unemployed rate was 150.8 per 100,000 for suspected suicide, and that compares to 126.7 in the previous year's annual report. Thanks, Ros. Next slide, please. And this looks at some of the suspected suicides that we had reported by deprivation fifth. And we can see from this that the rate was statistically significantly higher in people who lived in the next most deprived area, and statistically significantly lower in those who lived in the least deprived areas compared when we compare it to the all Wales rate, which is slightly different to last year's findings, where we found that the most deprived areas had the highest rate and the least deprived areas had the lowest rate. The confidence interval on the chart suggests, though, that these numbers are not overly robust, I suppose, and that so we just need to use a bit of caution when we look on those year-on-year rates. Next slide, please. And when we look at the regional rates, so we've broken it down by North Wales, Mid and West Wales and South East Wales. We found the highest region was in Mid and West Wales, although not statistically significantly higher than Wales. And this is slightly different to last year, where the highest rate was in North Wales, although the rate in North Wales in 24-25 is 17.3 compared to 14.9 in the previous year. Next slide, please, Ros. Thank you. And when we look at Health Board of Residents, we can see that rates varied quite a bit by Health Board. And Powys showed a statistically significantly different rate to Wales. It's slightly higher. And this is quite a bit different. You can see 25.3 per 100,000 compared to last year. Powys was 9.6 per 100,000, although the year-on-year rates and the difference in those combined with the wide confidence intervals suggests we've got a little bit of random variation, and that could be associated with small numbers. So we just need to use a little bit of caution when we interpret those rates and consider what our options are. Cwm Taf Morgannwg was also significantly lower than the Wales rate. Next slide, please, Ros. And yeah, just looking at the associated factors. So we've got, when we look at this chart, we just need to be aware that there are multiple factors associated with suspected suicides. So if you counted up the number of suspected the factors for suspected suicides within this chart, you'd get over 440 because there were multiple kind of factors associated with those suspected suicides. But we found that there was 61% of mental health conditions, 61% of suspected suicides had suspected mental health conditions, and also 55% have previous self-harm. And this is similar to last year's pattern, where it was 63% for mental health conditions and previous self-harm was 53%. Next slide, please, Ros. And then known to mental health services. So we looked at suspect suicide and whether they're known to mental health service, and what we found was 128 people were known to mental health services, which is around 29% of our suspected suicide, but 202 or 45% were not known, and 110, which is around 26%. We don't know whether they were known or not, so we're not sure on that one. And this is kind of broadly in line with the pattern that we showed last year, where around 30% of people were known to mental health services. Next slide, please, Rod. And this one shows known to police. Now we changed the definition on this from ever known to police to known to police with or previously known to police within the last 6 months. So we've kind of, I guess, tightened that pool of people that would be known to police. So we found that 137 people, or 31% of people, were known to police in the last 6 months prior to their death. The most common reason for being known to police was being suspected or convicted of a crime, which was around 81 people. And then we had vulnerable person or a victim of a vulnerable person they were 44 suspected suicide, and victim of crime was 17. And this is not dissimilar to last year's pattern. Again, known to police was around 35%. Again, that definition, as well as the new data, would have changed from last year's annual report. Next slide, please. And mode of death. So we recorded the mode of death for those suspected suicide, and we found that hanging, suffocation, and strangulation was the most common, and it accounted for 57% of suspected suicides. And then we had 98 suspected suicides from poisoning, which accounted for about 22%. Which is very similar to last year's figures, where hanging, strangulation, suffocation were around 57%, and poisoning was 20%. Next slide, please, Roz. Yeah, and this shows a location of death. So we have suspected suicides by where those deaths occurred. So for 59% of suspected suicides, they were in private residence, and that was the most common sort of place. And then approximately 35% occurred in public spaces, as mentioned, sort of woods, forests, places where you can, that are not at the home, basically. And this is sort of broadly in line with the 2023-25 data. There were sort of counts that were under 5 that are categorized within the other category. Thanks, Roz. Next slide, please. And I think that's back to you now.
Thanks, Rhys. Thanks very much. So I'm going to talk you through some insights from the first 3 years of RTSS. So we did some analysis of data from the 1st of April 22 to the 31st of March 25. And the things that we thought would be appropriate to pull out of this data, and following some feedback from users, was to look at local authority rates, most common associated factors by sex, domestic abuse by sex, and most common modes of death by sex. So this chart, it's a little bit small, but you can see that the local authority 3-year rates are here. And the interesting thing about this one is when Rhys presented, he talked about Powys Health Board area, and that was the only health board area that was of statistical significance on the health board chart from 24-25 data. But Powys is the only health board that has the same footprint as a local authority. And as you can see from this chart, using 3 years worth of data, the rate is 18.5, and it's not statistically significant. So when you look at the rates over a longer period of time, it sort of irons out the fluctuations and variations when you have relatively small numbers. But having said that, there is one local authority which is statistically significantly higher, and that is Blaenau Gwent, as you can see on this chart, which is 21.3 per 100,000 people. So then we looked at most common associated factors by sex. So we just looked at the 3 most common factors. So as you can see, it does differ by sex. So for males, the most common risk factor, most common associated factor was mental health condition, where 56% of males were reported to have a mental health condition, 49% of males were reported to have previously self-harmed, and the 3rd most common for males was family and/or relationship issues. And for females, it was previous self-harm that was the most common, but mental health condition was a very similar percentage. And 3rd most common for females was long-term illness, chronic pain, or physical disability. Then looking at domestic abuse by sex, men were more likely to have been reported to have been perpetrators of domestic abuse, and females were more likely to have been reported to be victims of domestic abuse. So we can see here that 22% of males were reported to be perpetrators of domestic abuse, and 23% of females were reported to be victims of domestic abuse. Then we looked at mode of death by sex. So hanging, suffocation, strangulation was the most common mode of death for both males and females, but a higher percentage of males died by hanging, suffocation, strangulation compared with females, and a higher percentage of females died by poisoning compared with males. So it was 32% of females compared with 17% of males. And as you can see, the third most common for males there says other or unknown. Now, other refers to the less common modes of death that are not in the 6 main categories. So that it's all listed in the glossary of our report if you want to see what other consists of, but there's quite a few sort of less common causes of death in that category. So that concludes the insights into using 3 years worth of data. So just to look at what's next for RTSS. So we've got a few things planned for the next year. So we are going to be doing some evaluation. We're going to be linking the RTSS cases with the ICD-10 code from the ONS. So this is basically looking at, was the suspected suicide an actual suicide as deemed by a coroner, or was it was there another cause of death? So how good is the RTSS system at identifying suicides, and then also looking then how many have we missed, and then we can look at doing some data quality improvements to to try and identify how many where we missed these from and how we can collect that information in future. So we are making ongoing data quality improvements, looking at the data flows coming in, looking at where we can look for additional sources. For example, when an individual may die, it may not be a sudden death, they may die sometimes later in hospital. So that data may not be coming in from the police. So we need to look at how we can capture that information. So we have as complete as data set as possible. And then we spoke about the unemployment rates and looking at the known to police data. So we are exploring unemployment data a little bit more with the Department of Work and Pensions to see how we can improve that and to get further insights into that. And looking at the criminal justice data further to look at whether we can start collecting information on people's use of probation services, etc. So we can try and build these into the surveillance. And then we're going to be doing some more engagement with the users of the data to understand their needs. And we hope to be able to start using the data for research purposes to be able to answer more questions that we're not able to answer when we're doing surveillance, but which would require sort of linking with other data sets. So those are things that we have planned in the future. I just want to mention that we will be sending out a feedback survey on the annual report in early 2026. So hopefully it'll give you time to have a look at the report, hopefully use it, and then be able to feedback on what was useful, what wasn't useful, and what you'd like to see in the future. So we'll make sure that's circulated. And if you want any further information, there's our website. All the reports are published on our website. That's the link to the annual report. So you will receive these slides. You can link directly to it. And there we've got generic contact email, and there's my email address. And I just want to give a final shout out to the National Police Chiefs Council and British Transport Police, who set up the Great Britain suicide surveillance system in the first place and allowed us to use their data collection form, and the 4 police forces and British Transport Police who provide us with information, which we couldn't do RTSS without that. The monthly RTSS Operation Group members, and of course the RTSS team in Public Health Wales. Thanks very much.
Oh, okay. For some reason, my camera has stopped working. So you'll just hear my voice. Thank you all. The 2 Davids, are you happy to rejoin?
Yeah, I'm here.
Brilliant.
Yep.
What I'm going to do is we had some questions via email earlier on, and I'm going to just ask those people to ask those questions. But I guess one of the discussions was that what was happening in the chat was, I guess, really about how the data is collected. So, and what influence that would have by what people mean by had a mental health condition. So I just wondered if you could elaborate on that.
Yeah, thank you. So the data is collected via the police's sudden death form. So when they attend a sudden death, they would fill in a form with a lot of questions on it. And a lot of those questions then are inputted into our data collection form. And they also would gain additional information from their police systems, and perhaps they'd be able to access mental health systems via the police, and also from family statements, for example. So they would collect all that information and put it on the data collection form. So, and we do try and cross-check as much data as we can. For example, I mentioned Welsh Clinical Portal. So if there's information about mental health use of mental health services, or whether the person had a mental health condition, we do try and cross-check that, but it's not always available. So basically, and also across the police forces, it may be collected slightly differently as well. It depends what they have access to, but generally it would be family statements, the police systems, and mental health systems as well. So, and they tried, in terms of the mental health condition data, they try to report on it if there's evidence that a mental health condition had been diagnosed. But of course, we don't have any cross-checking with, their primary care record, for example. So, it is an estimate of that information.
Thanks, Ros. I guess so a lot of the stuff in the chat is really about, whether a condition is diagnosed or not, what someone means when a family might report anxiety or depression. And I guess, we've slightly joined forces, haven't we? So within the National Centre, we're going to work towards linking RTSSS into the SaIL Data Bank, which is a resource we have in Wales that sort of pseudo-anonymously links across primary care and secondary care data and a number of other data sets, which will mean that we will be able to look at, so people are talking about ICD-10 diagnoses and things. We'll be able to look at whether people have actually had contacts with mental health services, when those were, what their actual diagnoses were in primary and secondary care. So I guess some of the questions and discussion in the chat are things that we're working towards, I guess is fair to say, isn't it? So I was wondering is John Carden still on the call? You'd emailed a question, and I wonder if you could.
Yes, I am, Anne. Can you hear me?
We can.
I actually forget what the question was but I think you alluded to it previously, and I think it reflected some of the discussions in the chat around how we identify mental health condition, mental health status known to mental health service. Given that I think the 3-year annualized data, you said that males by factor mental health condition was the highest rating factor. I think you mentioned by about 56%. I would suggest that would be the most important area to try and improve the data collection. And as you just mentioned there, given that the 77% rate this year seems to be creeping up a little bit, although fairly stubbornly high, I would suggest that was the most important area to try and improve that data set. All the data is important to improve, but working in secondary mental health services, as a lot of people are on the chat, I think we'd be more concerned about that, given that's the highest rating factor.
Do you want to respond first, Ros?
Yeah, thank you. Yeah, so I mean, it is important to bear in mind that the data comes from the police. It doesn't come, directly from mental health services. It would be really good to, in the future, explore how we could potentially get some information from mental health services. There's not one centralized system, apart from, as I mentioned, Welsh Clinical Portal, which is used variable, but, in the future, it would be good to explore that. We do actually have a bit more information than is presented, which is all we present is known to mental health services in the previous 6 months. We do have some more information on that, but we haven't analysed it yet. It's quite complicated. We've done a bit of work to figure out how that could be kind of recorded in our database and how it could be reported. So that's really the next step, is looking at that data and then looking, analysing that and seeing what that looks like. Is that helpful? And the way we're presenting it. So we do have some. We just haven't been in a position to do much with it at the moment. But it is on our radar to sort of to try and explore that data more, definitely, because we realise how important it is. And as Anne mentioned, there's the linkage with SAIL, which will be able to answer a lot of these questions as well.
And I've just put a link in the chat of a piece of work where we linked the National Confidential Inquiry data into SAIL and looked at contacts very specifically with mental health conditions and other diagnoses, which might help those from mental health services, while we're working to improve how RTSSS is working. And then there was another question from Tommy Carr. Are you still on the call? Nope. So Jan Roberts, you had a question.
Hi, yeah, thanks. So that I've got two questions, so I'll just say them now. So one is whether we can have the shared monthly, basically whether we can have this shared on a monthly basis for those of us that work in suicide prevention or are actively organising prevention activity in our area. So that's the first one. The second one is whether we can get a combined location of private residence with the private shed and garage, just because that's what we're looking at when we're looking at numbers of people exposed. So it's really useful when looking at, is this a cluster, what are the connections, how many organisations and individuals have been exposed or could have been exposed. Thanks.
So I guess
Sorry,
that's you, Ros.
Yeah, sorry, I didn't catch the second question, but shall I answer the first one first? So so I mentioned there, Jan, about the engagement that we're going to be doing with users in the future, and that will include we're going to start off hopefully in the first quarter of this year with health board users, so local public health teams and people from mental health services and other in the health boards. We currently do share data with local public health teams, so they get access to the report at the moment, but we will be doing that wider engagement with health board colleagues as well. And the second question was about private sheds and garages, but I didn't quite catch what the question was. If you wouldn't mind repeating it, please.
Just whether we can combine the location for private residence with the location for a private shed and garage for information, because when you're looking at the number of people potentially exposed to the death, it's helpful to be able to combine those two.
Yeah, that would make sense, and that's something we can definitely look to change.
Thanks, Jan.
With the sharing to public health, I'm aware of that our public health I think would feel that they needed permission to share with suicide prevention leads, so that's just an addition to that query.
I think very much the system that Ros is setting up, it sounds, it's been around for 3 years. That sounds like a really short period. Actually, to get all the agreements in place, collect the data, do the sorts of analysis that Rhys and Ros presented, that's an awful lot of work. And I guess, they're really doing a lot of stakeholder work now, and of which in many ways this webinar is one, to highlight what people want, but in order to do some of the things that are being suggested, which absolutely would put more information for action in the system, you know, that we need to work out all the sorts of agreements. But I know that Ros is very focused around this work. We had another question from Kate Miles.
Hi, I'm not sure what question. I put a few statements in the and thoughts in the chat. It's Kate from the DPJ Foundation. I know one of the points that I made was whether we can have any further information regarding the conditions that, so looking at the data for the top three, we had self-harm for women, then mental health conditions, and then we had physical health conditions. It would be really helpful to understand a little bit more about whether there are any commonalities there, so that the you know, the healthcare pathways can be adapted so that if women are presenting with, for example, endometriosis or something like that, then their mental health and their suicide risk can be considered and taken into account. I know that was one of the points that I wanted to make and to ask whether there's any way that we can do that, Ros. I know there's something that Sian's responded to me from Dyfed-Powys Police to say that it's a free text response. But we, you know, I've sat in rapid response meetings where we've been advised by the GP that there's no obvious risk, and then we see their medication history and they're on a cocktail of medication which suggests a chronic pain condition. So you know, so that link between the physical and mental in suicide has to be taken seriously, I think.
You
Shall I
go,
come
Ros.
back, Anne? Yeah.
You go, Ros, and then I've got.
Thank you. So, I mean, it depends on the detail that we get in our notifications, really. And as Sian from Dyfed-Powys has said, you know, it's in the free text box, so there'd be a lot of extracting of information needed. And whether that detail is available across the board, I'm not sure. We'd have to do some scoping work to understand that a little bit more, because at the moment it's just in that high level group of, you know, chronic condition, chronic pain, for example. So that would need a bit of scoping for us to understand whether that would be possible.
I just wonder whether the form could be adjusted to include a specific question around, are there any physical health conditions that we're aware of? Because then that will inform the questions that are asked by the police, perhaps when they're conducting that initial, you know, initial inquiries, and at the rapid response, where there are rapid response meetings that take place.
Unfortunately, the form is not our form. The form is a Great Britain form, which was the NPCC and BTP kind of British surveillance system. So we are actually using their form. So it's not, we've, you know, there are a number of things we would love to be able to add, but it's not as straightforward, unfortunately, of just being able to add a question. And then also there's obviously the burden on the police, because they can only ask a certain amount of questions at the time, and also there's the and you know, and extract that information at the time. So we would love to be able to ask more questions, but we have to kind of appreciate the limits of what we're able to do as well, unfortunately. But I think there may be other ways that we could get that information. For example, the SAIL work that Anne talked about. So maybe doing that in a research capacity rather than a surveillance capacity could be more appropriate, because the data quality would probably be better anyway, because it would be from a health source. I think Anne might want to come in and elaborate on that.
Yes, so we're doing a few pieces of work around this. So there are weaknesses with recorded data. So what the sort of data that I work with, people have got to contact services, their condition has to be recognised, and then that condition has to be recorded. But it's probably more accurate than more accurate and complete than what's recorded in RTSS at the current time. So and we're doing work in a couple of ways. So you can do it either by choosing the condition and seeing if there's a link, or you can use machine learning / artificial intelligence techniques to look at what recorded symptoms and diagnoses are associated with certain outcomes. And we're currently doing both those pieces of work. So research adds depth to the sort of data that we're talking about here, but the timelines are different. So the thing about, you know, the RTSSS data is it's giving us information that's sort of in near real time, so that, you know, for practitioners, you can respond quickly if there's a need. And for some of the questions that you're all asking, you know, the sort of research work we do, you know, particularly looking at neurodiversity, we've done a lot of work on neurodiversity, is probably more accurate and complete, and gives us patterns where you can believe the answer that you come up with more accurately. So I think it's really like the three sets of data that we're talking about here. You know, maybe when we do this next year, we'll also do a bit on SAIL and some of the work we've done in there, just to show that you need all these different systems to give you a true picture. Reese.
Yeah, thanks. It's just to sort of echo your point there, Anne. I think is something that the USP, I guess, of the RTSSS is that it is the lag time between when a suspected suicide occurs and when it's reported is a lot less, which is kind of a lot different to what the David's talked about around some of the lags that they have. But that shortness of that lag, you have a trade-off then with quality. And yeah, just to sort of back your point up, really, that trade-off means that the quality may not be there, but the timeliness is. So it's, yeah, I think it's a really important thing to remember that this is a rapid surveillance system.
Yes, and I guess, yeah, next time we do one of these, and I think we're planning on doing them every year, we could open with showing the strengths of all the different systems as they're all evolving. I'm going to give the final question over to Jackie Williams before we close.
Thanks, Anne. I submitted my questions before the workshop. So, Ros, I think you've answered one because it was around data quality and those assurances. And I think while I've got the opportunity on the floor, I'd like to say a huge thank you to you and your team for a phenomenal piece of work. I mean, I know there's still a lot of questions, and I'm sure there's a lot of things that you would like to do as well, but thank you. So I suppose the question that I don't think has been addressed is around the inclusion of presumed suicides. Locally in Gwent, we've had two presumed deaths. So there's no body has been recovered yet, but there's such strong evidence that it was a death by suicide. I don't think our police force are reporting those as suspected suicides. So I just wanted to check, should it be reported, and how are the other three police forces, I suppose, reporting those? Is there consistency in that reporting method? Thank you.
Good question, Jackie. Thanks for the question. So I think what I would do in that case is consult with our English colleagues to see what they're doing in near to real-time suspected suicide surveillance. I don't think, I mean, their source is the same as ours in terms of the data collection form that the police fill in for the wider Great Britain surveillance system set up by the NPCC, British Transport Police. So I would consult with them as well to see what they're doing, because we don't obviously want to be in line with them. But it's a really good question, and I will take that back. Thanks, Jackie.
So that passed really quickly. I think that was an hour and a half, and I have more questions, but I don't think I have time to ask them. Cherie, you were asking for the Critical Care Foundation infographic. I tried to get my team to send it, but it doesn't seem, unless I've missed it, it hasn't happened. If you put your email in the chat, I'll send it to you over email. Just to thank all the speakers. I guess, you know, when people present graphs and data, that can be really hard to talk about clearly. And I guess sometimes what looks like a simple graphic in front of you, the amount of work that goes into producing that, the thinking about the relationships, the ensuring that the quality of the data is okay and you're analysing it in the same way, can be really hidden. So I'm sure alongside all of you, just thank you all for the work that you're doing, and that, like, even the level of thought that ONS are putting in how to make the sort of suicide bulletins and data as useful as possible to everyone. So thank you all. I think, considering you were all talking about numbers and graphs, you all spoke in really plain English, and that doesn't always happen. Given the level of enthusiasm here, I think Claire Cotter from NHS Performance and Improvement and myself from the National Centre, I think we'll hold these annually just to sort of give a data update. But thank you all, and see you all again.